This week on Inside Olympia, November is open enrollment month. What options and prices will Washington residents find this year at the state's Health Benefit Exchange? We'll ask the exchange's CEO, Ingrid Ulrey. Plus, Medicaid enrollments are dropping nationally while costs are going up. What's the trend in Washington? We'll get an update from Dr. Charissa Fotinos, the state's Medicaid director.
From the TBW studio, it's Inside Olympia with host Austin Jenkins.
And welcome to Inside Olympia. Nearly 2 million Washingtonians get their health care through the state's Medicaid program, also known as Apple Health. Nationally, Medicaid enrollments are dropping while costs are going up. What's the trend here in Washington state? In our second half, we'll ask the state's Medicaid director. But first, November is open enrollment month. That means people seeking individual health insurance plans can shop on the state's Health Benefit Exchange. What options and prices will they find this year, and what types of subsidies are still available? Joining me now is the exchange's CEO, Ingrid Ulrey. Good to see you again for our annual chat.
Austin, thank you so much. Thanks for having me on. This is my second open enrollment season as CEO of the Washington Health Benefit Exchange. And basically, though, my whole career, I've been working in and around this work. I was thinking back this morning to the fact that this is our 12th open enrollment since the ACA passed in 2010. And back in 2010, that's when I met you, Austin. I was the advocacy director for AARP Washington. Yep. And at that time, the uninsurance rate for our state was over 14%. And you fast forward to today, we have now just less than 5%, sort of record low uninsurance rate. So we've come a long way. Many more people who were shut out of the system, many more are now covered, and we've got a lot more work to do. So we're just highly aware, that coverage doesn't always mean access, that we have disproportionately high uninsurance rates in communities such as our Black and Native communities. And affordability is a huge barrier.
Yeah, and we're going to talk about that because the costs keep going up. I think just for context, I used those stats, about 2 million Washingtonians in Medicaid. Mm-hmm. In this realm, we're talking about 250,000 people, give or take.
Give or take, it's 270,000. So we had record high enrollment last year, and we expect to meet or beat that this year for a couple reasons. One's related to Medicaid and your conversation with Dr. Fotinos. As you know, they reinstituted the COVID era pause on annual eligibility checks. So from April to April 23 to 24, those were reinstated. So we had a number of people dropping off the Medicaid program.
Because they're no longer eligible.
Right. And those that income up and were, they got a job, they had more resources, we've been welcoming them into our market, and many have regained. We've had actually more than 75,000 regain coverage through the exchange in our market. So we're starting from a higher base, highest enrollment ever last year. And then the most important and really unique thing this year is the continued availability of the federal enhanced premium tax credits, plus our state subsidy, which is called Cascade Care Savings. So those two things together have enormous power. And even though our premiums continue to increase in our market, the availability of the federal tax credit and the state subsidy means that on average, people who are eligible for both, which is a large number of people in our market, can expect a plan to cost on average $70 per month this year in the exchange market. So we encourage them to come in.
We'll talk more about these credits and subsidies and how they work and how long they're going to last in a moment. But bigger picture, who are the people who are, you mentioned sort of the people rolling off of Medicaid who might be getting insurance through the exchange. Who else is buying insurance this way?
Absolutely. So the people who fall outside of the healthcare system that most people rely on will be through their employer, health insurance coverage through your employer, or health insurance coverage through the Medicare program. So we have everything from young adults who are just coming off their parents' health plans at age 26, or maybe early in their career. They have a job, but it doesn't yet come with health coverage. Small business folks are a big a part of our market as well, including micro businesses. So they're not big enough to have an employer plan, and they're often accessing care through the individual market. Also, a key market or customer segment for us, if you will, are people who are on the bridge to Medicare. So they're older, they're retired, but they're not quite Medicare eligible, and they rely heavily on this market.
So the headline from the Insurance Commissioner's Office is that the improved average rate increase for this year was 10.7%. And that builds on, I think, now 3 years of rate increases. And while that's the average, according to the Seattle Times, that there are plans that are going to go up by as much as about 24%. So help us understand, and you are the CEO of the exchange, but you also have looked much more and are looking much more broadly at cost drivers. What's going on here that's driving year over year double-digit average increases?
So this problem of ever increasing healthcare cost is much bigger than the exchange, and we're feeling it heavily in our market. So the major cost drivers out there we know are hospital costs, pharmaceutical costs, are two of the biggest examples. So there are broader efforts that the exchange is involved in to address those ever-rising costs and move towards the goal of our benchmark set for our state, which is 3% per year increase. And as you said, we've had double digits in the individual market. So prices, the thing to know about prices, so people are out there and they maybe meet one of those criteria that I described, is prices vary based on age, income, geography, in our market, can vary widely. And I think the key thing that is important is so many of our customers, 80%, are eligible for the federal premium tax credit, which is massively reducing people's costs and has been a very helpful driver to keep people covered.
What is the Insurance Commissioner's Office said a key driver behind these rates is the increase in services used and the cost to deliver that care. Does that just mean people are using their insurance more, going to the doctor
Let
more?
me just say it more simply. So healthcare, the cost of healthcare, what's driving healthcare costs are utilization and price. So in terms of utilization, we want to encourage utilization for preventive services like primary care. There is some low value care that has been identified that there is some care that we could be avoiding, but primarily the most important mechanism to get around to reduce healthcare costs is around price. So our public option plan, first in the nation, and we're very grateful for Governor Inslee for supporting that, does that through what's a reference-based pricing mechanism, basically setting the aggregate price at an aggregate percent of Medicare.
Okay, so we know prices are going up, and we know the exchange can't directly control that.
Yep.
And so people coming into the exchange are going to see higher prices, but the offset can come through subsidies and these tax credits. So explain to us again sort of what's on the menu when you come into the exchange in terms of you have sticker shock because you see what the price is going to be, but then when you calculate those discounts, if you will, maybe you get to that $70 a month on average. What's available to get the cost down?
Sure. So first of all, the place to go is WashingtonHealthPlanfinder.org, our platform, our portal. The system makes it very easy. So people plug in their basic information, and it illustrates their eligibility. So people could come in. They might be eligible for Washington Apple Health, the Medicaid program, and they will be referred.
Oh, you'd find that out there, too.
Yes.
Okay. Same
Portal. So they come to Washington Health Plan Finder. During open enrollment, which kicks off November 1 and goes through January 15th, people come in to Washington Health Plan Finder, put in their information, and it will show them the plans that they're eligible for in their area. And it will show them their net premiums and also the cost-sharing structure. People can also plug in doctors that they are important to them to be in their network. So it's pretty user-friendly. We find that most of our customers are able to self-serve by going through our portal or our mobile app. But shopping for insurance is complicated. So we have a smart plan finder that will show them the plans that might be most relevant and cost efficient for them in their situation. If they need more help, they can call our customer support center. They pick up the phone really fast during open enrollment and operate in over 200 languages. And they can also be referred to an in-person assister in their community. We have more than 3,000 brokers and navigators across the state of Washington to help.
So the subsidies or the offsets are two things, right? So there's federal tax credits and then state subsidies?
That's correct. So the enhanced premium tax credit is the federal, and in 2021, through the American Rescue Plan Act, that was expanded. So there's more credit available, and
So even
more
as prices
people
are going
eligible.
up, there's actually more credit available.
Yes, and so since 2021 and continuing through this year, 2025, people can access assistance and get greatly reduced premiums through those enhanced federal premium tax credits.
Are there income caps?
So it previously, before 2021, it was up to 400% of the federal poverty level. So that's a middle income person. It equates to approximately $58,000 a year. So that cap was taken off in 21. Now it's anyone no one should be paying more than 8.25% of their income on health insurance. So at this point in time, and this year for 2025, next year, people of any income level can come in if they are paying less than if they would have to pay more than that amount of their income to health insurance, they would get the tax credits.
Well, how do the state subsidies work then?
The state subsidy is a flat monthly amount that's provided on a sliding scale to individuals at the lower income levels, and it's been really critical and successful in keeping people covered who are coming up income off of Medicaid or Washington Apple Health, and helping them support so they can purchase a private plan on our market, as well as it's really important in the rural areas. We're finding that the Cascade Care Savings state subsidy, the highest percent of customers are in counties such as Ferry County, Lincoln County, Yakima, Grace Harbor. So it's important for low-income individuals who are really just on the cusp of being able to afford private health insurance.
Crucially, you mentioned that the federal tax subsidies are set to expire after 2025, in 2025?
At the end of 25. So for this year, really robust support is available both through the federal government, through the tax credit, enhanced tax credit, and through the state subsidy. So those two combined, people can expect to pay just $70, an average of $70 per month in premiums is what can be expected if people are eligible for both. The challenge, Austin, is that enhanced federal premium tax credit is set to expire at the end of 2025. So if Congress fails to take action, that will go away. And we are very concerned. Take an example. I'm going to give you an example. So 60-year-old woman in Yakima, maybe she had coverage through her husband's employer. He retires, he goes on Medicare. She has 5 more years until she's eligible for Medicare. Currently, with the enhanced federal premium tax credit, her premium might be round about $1,500 per year, which is steep but doable. If Congress lets the enhanced part of that tax credit expire, it would more than double, so over $3,000 per year, which is really hard, which for many people can make or break it. And I remember when I worked with older folks at ARP, people would say, oh, I think I'm just going to cross my fingers and hope nothing goes wrong until I get on Medicare, which for that age group, that population is very risky and can lead to people having medical debt.
So getting Congress to do anything is tough these days. What are the conversations like in terms of renewing that, but also at the state level? Is there anything the state could do to step in?
Thanks for asking. We've been providing regular data and information to our congressional delegation. There may or may not be action in the lame duck, and we'll have to see after election when Congress brings this up. We hope they act quickly in 25, at least to extend, if not to make permanent. Otherwise, it'll create uncertainty in what the prices will be for plan year or calendar year 26. In terms of what the state legislature can do, this all provides heightened importance to our state subsidy. There's no way we will replace the robust amount of federal funding that's coming to our state now. That enhancement is equivalent to about $250 million per year.
That's real money. Coming
to Washingtonians. So for Cascade Care Savings, the state subsidy, funding for that drops after year 2025. So our primary ask to the legislature, to our new governor, the new administration, is to ensure ongoing funding for Cascade Care savings and to enhance it to protect people against blunt the blow, if you will, of what may happen in 2026.
Well, this seems like this recurring conversation when we talk about the sort of cliff that looms, right, and the uncertainty. The system is, you don't have control over the prices, and you don't really have control over the subsidies, at least not on a long-term basis. So what is it like to navigate? Like this year you could say, look, I'm really happy with what we can offer in terms of maybe don't love the price, but we can sort of offset that.
Yeah.
But knowing that there is this cliff looming and that there's no guarantee, and you're kind of constantly in this mode of trying to shore those up. What's that like?
Well, Austin, I would say, I think we all have to be clear, we can't subsidize our way out of this. Right here in the here and now, the federal tax credits and the state subsidy combined are providing something really important. They're keeping people covered and keeping them out of medical debt and keeping them healthy. At the same time that we encourage the continuation of the subsidies to keep people in the here and now healthy, we need to be looking at longer term solutions. So we're really grateful to the Healthcare Authority for chairing and hosting the Healthcare Cost Transparency Board. There's important conversations happening there, as well as with the Office of the Insurance Commissioner, the affordability report that they put out. I'm seeing, 2 or 3 issues that we hope will gain traction and that we can work with our state legislators for a longer term future of controlling healthcare costs.
Call me a skeptic because we've been talking about this, for a long time. I remember Chris Gregoire when she was governor talking about bending the healthcare cost curve, and that was like 20 years ago. So what gives you hope, and you've worked in this field for so long, what gives you hope or optimism that something in the nearer term could start to change that curve? Because all I'm hearing is we've now got these new cost drivers, weight loss drugs, these biologics that are really expensive, so on and so forth. All these new things that are costing more, how are we ever going to get ahead of this and start to really bring costs down so then we don't have to subsidize and offset, play this kind of funny game?
I'm going to call you a skeptic, Austin.
Not a cynic, okay.
Because as I just pointed out, when I started in my career, even before 2010, I was in California working on health coverage, healthcare access. We had 29% uninsured. Did I ever dream that I'd be sitting here with you in 2024 saying we have less than 5% of the people? We're on the road to universal coverage. But coverage doesn't equal access because we're going to continue to have the nag around affordability until we can take a hard look at costs. And the problem is we have strong vested interests against all of these proposals. But what I'm seeing, I would give you 3 examples of things that I hope do and should have traction. One is how we spend our current money needs to shift. Right now, we only spend 2% on primary care. Primary care is what keeps people healthy before they get a disease and need hospitalization. So coming out of the consensus of conversations in our state, I think there is consensus on setting a goal of, hey, at least 12% of our healthcare spend should be on primary care. So that's one example. Another is that notion of reference-based pricing. Like, prices are all over the map. There's huge variation, and it's really hospital and pharmaceutical prices that are driving the problem. So our public option, which Governor Inslee and leaders like Eileen Cody and Senator David Frocht were great champions for, we're using that tool, and that's why the public option plans are the lowest cost plans in the majority of counties and have the lowest rate of cost growth. So reference-based pricing could be applied to other markets. So we hope and envision that there will be a move. That's really a logical next step as outlined in the OIC affordability report.
Right, the Office of Insurance Commissioner put out this report on ways to address healthcare costs. The term you just used, reference pricing?
Reference-based pricing. Sorry, it's a wonky term.
So what is it again?
So it's saying that instead of the price just being determined through the negotiation of a provider system and a carrier, there is a set price that it needs to be referenced to. So the Medicare program has a fee schedule. So in public option, we say your prices across the board have to, on aggregate, be 160% of Medicare. So more than Medicare pays, but not a huge amount more, because we're seeing prices 200, 300% of Medicare, which is what's not sustainable.
And the private plans are not adhering to that.
Correct. Reference-based pricing is really only in place through public option in our state right now, but could be applied, for example, to the public employee or school employee benefit markets.
When we get into the exchange and then people are making their decisions about where to go, what percentage are going to the public option?
To all the Cascade Care plans, including just the standard plans and the public option, we're up to 76% of people walking with their feet towards those plans. Public option is lower because there are fewer public option plans on our market. So we're really pleased that this year, for the first time ever, we'll have a public option, if you will, in all counties. We just got that through in Lincoln County and Grays Harbor.
So what is the difference, or how would I know, when I'm looking at the choices?
Yes, this is how you would know. So there's a logo that shows it's a Cascade Care plan. It's a picture of the Cascade Care Mountains and a little circle. For consumers, they don't need to understand like all this complex policy, but we really encourage people to look for the Cascade Care logo, because those Cascade Care plans are going to allow key benefits, including access to care like primary care before the deductible, on average lower deductibles, as well as a standard benefit and cost structure. Because Austin, what happens is people get so confused by the cost sharing, for example. So having a set caps on how much out-of-pocket costs you could be liable for protects you from risk.
Is there any downside or trade-off if one goes with the public option versus a private plan on the exchange?
They're all private plans. So I know that's a funny term, public option. Truly what it is are private plans that are publicly procured. So that the carriers, for example, are Coordinated Care, LifeWise, Community Health Plan of Washington, are procured by the healthcare authority and agreeing to adhere to the aggregate price cap.
But is it the same? Is it the same plan, or is there any trade-off?
They're very similar to the non-public option plans, but on average, they're less expensive because of that price cap.
Is there any reason a person would go into the exchange and not just go to that?
People need to look at the network. So some of the trade-off with some of the public option plans is a narrower network. So people need to make sure they're looking carefully, is my preferred provider, my specialist that I need for this or that, are they in the plan? That's true with shopping really for any insurance, but particularly with the public options, we would recommend people make sure that the network's going to work for them.
In the few minutes we have left, I want to ask you about, there's this ongoing Boeing strike. I understand that Boeing workers who might lose their health care, or who do lose their health care, if that were to happen, could get benefits through the exchange because of a 2024 bill that allows, legislation that allows striking workers to get care. How does this work, and are you seeing any demand at this point?
Sure. So Senator Karen Kaiser championed legislation that was passed last session that it's pretty simple. It basically just directs the exchange to provide outreach and information to workers who've lost their health insurance due to a labor dispute. So when this Boeing strike came up, this was the first big example of us implementing that directive. So we produced information, some simple flyers, participated with other partners in rapid response presentations, simply providing what their options are so they don't have a gap in coverage. And so it's...
And they can enroll outside of open enrollment period?
Yes. They people who lose, that's a qualifying life event, so they have a special enrollment. And the workers who are on strike, I'm sure it's very stressful. They're looking at whether do I stay on COBRA? Do I have a spouse or other family member I could go on their plan? Or do I want to purchase over the exchange? So there's no financial benefit, like there's no paying of the exchange premium. It's simply outreach and education, and we've been doing our due diligence to get out to those workers in this hard time.
There was also an effort to expand access to these plans to people who are here who are not undocumented folks in Washington, and there was a huge response, but it was capped because of the amount of money the legislature appropriated to this?
Two things. Two related. So there's been a recognition by the legislature and the policy leaders in our state that everyone, regardless of their citizenship status, should have access to health coverage. And we know that 1 out of 4 people who are uninsured are undocumented. So this is a very important way that we can get to full coverage. So 2 things happened. year before last, we submitted a waiver to the federal government simply to allow people, regardless of their citizenship status, to shop for and purchase a plan on the exchange. They can do that. They can be eligible for the state subsidy, because that's what state law allows, but they're not eligible for those federal premium tax credits. So we've seen a relatively small uptick of about 1,500 last open enrollment of people who aren't eligible for the federal subsidy and who are not lawful citizens. So this has been a small effort, but important, and simultaneously, led by the Healthcare Authority, there was a capped enrollment expansion of a Medicaid lookalike program. Mm-hmm. So you can be on Apple Health. It's actually a state version of Apple Health. That was capped due to budget to $12,000.
That was on the Medicaid side of.
Yeah. So now on both sides, people can come in regardless of citizenship status.
So somebody who is undocumented in the state right now who doesn't have health insurance, what are their actual options as we head into open enrollment?
Well, they're very parallel to someone who does have documentation, who is a citizen. Mm-hmm. Pretty much the same. The main difference is, while the availability of slots on the Medicaid or Washington Apple Health side is limited. There may be discussion this session about expanding those, but right now it's full. So that's challenging. So the lowest income folks will have difficulty accessing Washington Apple Health due to the enrollment limitation. On the qualified or the ACA plan side, they're welcome to come in, open enrollment, purchase a plan, and they will be only eligible for the state subsidy. So those plans are more expensive than many would, then that will be hard for many people.
What about DACA recipients?
That's one other new thing this year is we're implementing a newly issued federal rule, which simply states that the Deferred Action for Childhood Arrivals, DACA, the Dreamers, if you will, are now newly eligible for the first time to receive the federal enhanced premium tax credits, and when it's no longer enhanced, they'll still be eligible.
So that's
going
new
to
for
help.
This year.
Yeah, and we expect the numbers to be small, probably at least maybe 1,000 or more. But these are really important policies that you're asking about to meet our equity goals.
Okay, we are out of time, but just a last message to people who are viewing this, listening to this, and might be trying to figure out what they're going to do about health insurance for 2025.
Thank you. So now is a really important time to get ready for Affordable Care Act ACA plan open enrollment. It starts on November 1. People can go in right now to Health Plan Finder, WashingtonHealthPlanFinder.org, and plan preview, window shop, if you will, and be ready to fill out the eligibility information and shop for and pick a plan to start in year 2025. If people want coverage to start right at the top of the year, they need to do that by December 15th.
Okay. Ingrid Ulrey, the CEO of the Health Benefit Exchange, thank you so much for coming in.
Thank you.
Appreciate it.
Okay.
When we return, while 270,000 people get their health insurance on the exchange, nearly 2 million lower-income Washingtonians rely on Medicaid. We'll get an update on that program from the state's Medicaid director right after this.
To hear both sides of the stories that affect your life, watch The Impact, from standardized testing to crime,
Police search warrant,
to taxes, to fish and wildlife. We break down complicated bills and agency rules to find out what's really at stake for you. Join us every day at 7 a.m. on TVW or anytime online at tvw.org for more in-depth stories you won't find anywhere else.
Welcome back to Inside Olympia. Washington's Medicaid program, known as Apple Health, covers nearly 2 million Washingtonians. Nationally, Medicaid enrollments are declining while costs are going up. What's the trend here in Washington state? And what is the status of the state's effort to extend coverage to people who are undocumented? Joining me now is the state's Medicaid director, Dr. Charissa Fotinos. Welcome back to the program. Good to see you.
Thank you, Austin.
So let's start with sort of the national perspective, which is that the Kaiser Family Foundation does this annual survey of Medicaid directors, and the word back in the most recent survey was we're seeing anticipating declining enrollment and seeing costs going up. What is the trend line here in Washington, where we've got about 1.98 million people covered by Medicaid?
So I think
it's important to clarify declining compared to what. So compared to the height of enrollment during the pandemic, when all states were mandated by CMS to say, if someone is on Medicaid, they will stay on Medicaid until the pandemic is over. And
We're not going to
we
kick
let
them
you
off.
know. Right. So the numbers obviously across the country increased markedly. I want to say about 14%, I think, in Washington, because we didn't disenroll anyone. People lost their jobs and they became eligible for Medicaid. So as the unwind took place and people were asked to renew, and those who responded and still were found eligible stayed on Medicaid, and those who either didn't respond at all or were no longer eligible for Medicaid dropped off, we're finding that in Washington, our numbers of people enrolled in Medicaid is about the same as it was pre-pandemic. So we've not really lost enrollment. Compared to the height of the pandemic, we absolutely have. But compared to the number of people receiving Medicaid, as a proportion of the population, it's pretty similar from pre-pandemic. One of the other things that, at least in Washington, and I would not be surprised if isn't true in other states, is that for the people who remain on Medicaid, they tend to be the folks who are sicker, have more complex problems, whether that's medical or behavioral health, because that's essentially how you qualify for Medicaid. Either you are living under a certain income level, or you are older, have disabilities that qualify you for Medicaid. So sort of by those definitions, you would expect to be in poor health. And so what we're seeing and hearing from some of our managed care plan partners is that the people who are remaining on Medicaid are needing to use more services. They have higher acuity or more complex problems. And when those folks are able now to seek care that they weren't during the pandemic, costs are going to go up because you're utilizing more services.
I know that when we last spoke, there was a lot of talk about how this unwind would happen and trying to do so in a way that people are informed, get to prove if they're eligible still, and aren't just kicked off and sort of, maybe they are still eligible, but they've been told, you can't be on anymore or whatever. So, and it seems like across the country, some states are getting better grades than others for how they've managed this unwind. What can you tell us about how Washington State approached this?
I from my position in the agency as Medicaid director, I think we did a really thoughtful, deliberate job. There were extended eligibility periods after someone sort of was required to respond, and that was 90 days. If they responded any time within that 90 days, and they had not even managed to respond before for a request for information for re-enrollment, they still could do that up to 90 days, and that would be retroactive. And we found about a third of the people who didn't respond at all to requests for renewal did come back within that 90 days and reactivate their Medicaid coverage.
So even if they didn't respond, but then they came back within 90 days after being
Yes.
disenrolled,
and we're eligible.
we're
Correct.
eligible, they could pick up where they left off.
And about 30% of that group who didn't respond did do that and re-engaged with their Medicaid eligibility.
What were you finding in terms of people not still being eligible?
I can't speak to the specifics, but one of the things that we noted during the duration of the pandemic is that a large number of people who were enrolled in Medicaid never utilized any services. So either they were not in need of services, they were young and healthy, they forgot they were on Medicaid when they went back to work. Don't know those details, but there were a large number of folks who had been newly eligible during that pandemic time who never accessed any services.
Is the unwind over with now? Are you done?
We're still reporting to CMS, but for all practical purposes, yes.
So let's go back to when all was said and done. How many people rolled off, or what was the percentage drop based on the rewind? Do you recall?
The percentage drop, I don't know off the top of my head. I can
That's
get
okay.
that for you. We saw a fairly large increase over the early part of the pandemic, and that growth stabilized. Then we saw a reasonably large drop in it. As I said, I think we increased our enrollment by 14% over the course. I can take a quick look here.
And I guess what I was trying to get at is how much, because the concern was that as states began to review people's eligibility, you would see quite a lot of attrition out of the program, and then people without health insurance. Do you have a sense of sort of in the final analysis
I don't think that we, as a state, did a bad job and harmed people. We went to what's called ex parte or auto renewals, and pre-pandemic, our rate of auto renewals was around, I can take a look here, 45%, but by the end of, as of September, our auto renewal rate was up to 80%. So a lot of folks, we just checked automatically at the time of their determination. So, what I can say is that as a state, we put in every possible sort of stopgap we could to keep people enrolled, make it as easy as possible, as many ways to re-enroll as possible if they require that information. So I don't think at the end of the day, again, our numbers sort of pre and post-pandemic in terms of volumes are similar.
Not that different, yeah.
Yeah.
Okay. So in the first half, we were talking with Ingrid Ulrey of the Health Benefit Exchange about increasing access to health insurance in this state for people who are undocumented. And one of the things we talked about was the Medicaid expansion program from earlier this summer where, and I'll have you explain it, but essentially there were slots opened up in the Medicaid program for individuals and families. And what seemed to happen is that those slots, there was huge demand and they filled up almost immediately.
Right. So slight clarification, it is a Medicaid lookalike program called Apple Health Expansion. The funds to pay for the expansion for people who are not eligible for benefits due to their citizen status is all state funds. So
Because
Medicaid
we should
is
explain
not.
Medicaid is a half and half.
Half and half,
And
and-
so under
correct.
the standard Medicaid, people who are undocumented don't qualify.
Correct.
But the state can say, we're going to stand up a fully state-funded.
That looks
and that's what we
like
said,
a
looks like.
Medicaid program.
And this was the first
Exactly.
time we had done this?
This is the first time we'd done this to this scale that I'm aware of, yes.
And so the legislature funded
Correct.
a certain number of slots.
The legislature funded an amount of funds that when we determined the program benefits to match those on Apple Health that is in part funded by Medicaid, we came up to around a number that it could fund around 13,000, and that's about the enrollment we're at.
And word got out, and I mean, it seems like this program started on June 20th, and by July 3rd, you were announcing that the cap had been reached.
Huge demand, and this is, but I mean, great expansion, great for the folks who were able to access, this program. We know the demand is much higher.
What is the argument for the state funding Medicaid look-alike slots for people who are undocumented?
From a just purely government sort of fiscal perspective, it makes sense. If you can pay for health care before people require catastrophic intervention or services, that saves money in the long run. From a sort of, personal, my personal perspective as a physician is that everybody should have access to health care. And so I think it's both sort of aligns with we should provide basic health care to everybody, and two, it makes sense. And a lot of the people who are not documented make up a huge part of the workforce in Washington, help generate a lot of revenue for a lot of the industry in Washington. And so to not be able to help cover the services, injuries, and the chronic conditions as they provide a bunch of services for all of us, it's just the right thing to do.
So based on the high demand for this, what are the conversations now about what to do with this Medicaid expansion, especially given that it seems like we might be coming off of the rosy budget years and heading into perhaps more austere times?
So from an agency perspective, we propose budget considerations to the governor. Mm-hmm. The governor then decides how he and the next governor will do the same after they're elected, decide how they want to manage their budget. They then provide those budget, they share their budget, the legislature then does theirs. What I can say is this is a valued program. We will be happy to respond to whatever we are directed to do from the governor and the legislature. in an ideal world, that would be to expand the program so more people can have access. And we know there's a huge interest both among folks who are interested in applying and continue to apply, as well as numerous stakeholders and advocates across the state who are very much invested and passionate about this program expanding.
Do you recall what the appropriation was to get the 13,000 slots? What this is
I
costing?
would misspeak if I tried to remember.
Just to be clear, is the agency, then there is not a budget ask into the governor to say, hey, let's double this or do something more? Is that right?
If I recall, we asked for a small expansion. I don't recall the request, and again, any limits on the request for consideration for expansion were based on the directions we're given, which are influenced by the financial forecasting and all the stuff that we're required to sort of formulate our requests around.
Let's talk about, we're talking about Medicaid enrollment trends. Let's talk about cost trends and what's driving costs, because that was the other piece of this national survey. Declining overall Medicaid enrollments, but we're seeing prices go up. What's driving that?
Maybe, and I don't mean to be flippant, but what costs aren't going up? I think we're seeing, a large increase in the price of prescriptions. That said, there are some tremendously effective breakthrough, amazing therapies out there that are expensive. They may be one-time or two-time drugs, $2 million to cure sickle cell disease. That's phenomenal. Right. I think there are other new cancer treatments that are very expensive. So I think pharmaceutical costs certainly have gone up. I can't tell you the trend off the top of my head. And we know from our hospital partners that they continue to feel the strain of the pandemic, and that costs for them in terms of assuring adequate workforce and labor with provider shortages, nursing shortages, home care worker shortages, have also, created a demand for workers, and so they're having to pay more prices to get that small workforce to where they need them. So I think it's a combination of things. I think the price of medical, everything, inflation, everything has gone up. So I think it's more a reflection of just general increases across the board than any one specific thing.
We're hearing so much these days about these weight loss drugs like Ozempic and their cost. I know in a lot of cases insurance won't cover them. People are paying out of pocket, but is that having an impact?
We do cover them for the indications that they are FDA approved for, so we do cover them. I think there is much more broad interest beyond people who have diabetes or who have heart disease, who there also seems to be strong evidence for. I think one of the interesting things that we're watching, and we will continue to watch, is every week there seems to be a new indication that research has shown these drugs are beneficial for. If that continues to be the case and these research studies really bear fruit, then I think it will force a different conversation about this particular class of drugs. If they're beneficial across so many conditions and the demand is high beyond just the desire to lose weight, but it benefits all of these clinical conditions, then to me that's an opportunity to have a different conversation about how we pay for pharmaceutical drugs, both not just at the state level, but at the national level. So I would hope it would continue to promote conversations about drug prices that here are much higher than they may be in other countries for the exact same drug.
You mentioned eliminating sickle cell disease, for instance, and new drugs coming online. A few years back, the big breakthrough was drugs to treat hepatitis C,
Yes.
but also super costly. The governor in 2018 signed a directive to eliminate hepatitis C in the state by 2030. I know that there's a partnership with the Department of Health to do that. How is the state doing towards that?
We're making progress. I think we've treated about 17,000 people, which with today's drugs means cure, unless they become reinfected, which when I started my career 30 years ago, the treatment was miserable. No one wanted to do it, and it wasn't as effective as now. So there continues to be outreach. We are also in a partnership with AbbVie, we negotiated this sort of prescription model price. You sell a certain amount of the medication and then you have a lower price for it. They have been partnering with us to have a mobile van to go across the state and do testing. So it's been a comprehensive effort. We we've had some, again, as you mentioned, great partnership with the Department of Health, really working to try to get the message out, try to get people tested, and if they test positive, really start people on medications, which, usually an 8-week course, 1 pill a day, and it's much, much better and easier to manage than it was years ago.
So costly, but somewhat miraculous.
Indeed, but with this sort of bulk purchasing, we guarantee you will get you this many people, and then a sort of price negotiation, that has been a model that pencils out in the end.
Take some of the sting out.
Yeah.
Something else that the state is working on, as I understand it, is to make sure that people coming out of prison have Medicaid so that they're not coming out of that environment and then not getting coverage.
Right.
What's that process look like, this reentry effort?
So with the Medicaid we submitted a renewal for our Medicaid transformation waiver. We had 5 years, and about in 2023, we submitted a request to extend that waiver for another 5 years, and we added additional services. One of the additional services we added was to provide and cover a certain set of Medicaid eligible services for people either 90 days before they're released from prison or 90 days from the time they're incarcerated in jail. And so what that requires correctional facilities who are interested in participating is that they provide care management for the transition of people who are incarcerated while they're there into community, provide medications for opiate use or alcohol use disorder while they're incarcerated. And
just to be clear, is Medicaid covering it at that point?
Medicaid, yes, Medicaid is covering that case
You said
management.
this was up to 90 days before release.
So basically for people in jail, there are a small percentage of people who are in jail for longer than 90 days, but the vast majority of people are
So this is specific
released.
to jail, not
And
prison?
prison, it's both.
And prison, both.
It's
okay.
both, right? So the difference being people who are incarcerated in jails come and go much more quickly.
Right.
So in effect, what will happen is if they have Medicaid, their coverage won't end for that first 90 days. And if they're not covered, the goal will be to get them onto Medicaid while they're incarcerated, if they're there long enough. And while they're incarcerated, they will have access to that case management, to 30 days of medication at the time of release, and then medications for opiate use disorder and alcohol use disorder. Those are all required. Jails can opt to provide more services as well, such as lab testing, broader clinical and behavioral health services, other services.
So just to be clear, is the new part of this the coverage before getting out, or is it the particular coverage for treatments, for addiction treatment?
Jails and prisons cannot bill Medicaid to date. What is new is that they will be able to bill Medicaid for these services.
And when is that?
July 1 is the
2025.
2025, correct.
And this is an optional thing for the jails to
Yes,
participate in?
yes.
And do you have a sense yet of how much interest
There is a lot of interest.
Yeah.
There's a lot of interest both from the Department of Corrections, because they'll be able to start billing Medicaid, 90 days prior to release, which is known. So a lot of interest on the Department of Corrections side, a lot of interest on the jail side as well, because they are required to provide health services, and so this will help, redirect some of the funds they're using now to provide those health services to their other services.
And I would imagine the thinking is if people can come out of incarceration and have access to these medications and have them covered going forward, that you have a better chance of them continuing with the regimen.
Absolutely. I mean, we know one of the highest periods of overdose risk is when people are released from incarceration, that the first 2 weeks after they're released is a really high rate of overdose death. I think the other piece that's really important and critical is that it's people who are incarcerated obviously have a lot they're dealing with, and sort of identifying healthcare needs and other social needs while incarcerated now. There's no one to hand that person over to continue to help them navigate our very complex system. But the addition of care management will sort of help bridge that. Here are all the needs that you've identified yourself and we've identified in terms of your health and mental health and substance use disorder and housing and food. Here's someone who can pick you up after you're released and help you get those services or link you to those. And I think that's a really key part because folks get lost in that transition and it can be a deadly transition.
You mentioned this Medicaid transformation project. What is it? More broadly, help us understand.
The idea of the Medicaid transformation or 1115 waiver programs that CMS offers are to be able to say, we want to try some innovative things. We want to create services that Medicaid dollars currently cannot be spent for because we think that if we implement these services, we will not spend any more money from a Medicaid budget perspective. We will improve
We'll save you
health.
money.
We won't spend any more,
Yeah.
right? We don't guarantee we're going to cut spending,
Right.
but we're not going to increase our trend of spending, and we're going to be budget neutral by providing these services. So there.
And examples are like what?
Well, the reentry
Yeah.
project would be one. Foundational community supports. Those were supported employment and supported housing for people who met certain medical criteria in our first 5 years of the waiver. And so they had help with either finding housing or employment and had those supported and showed that that got people more stable in housing and they did better. So those were able to be renewed. So they're 5-year demonstration projects and very popular. Most states have some versions or others with a variety of different programs that they're trying.
So we're in the renewal process. We are renewed.
We renewed.
Okay.
We are renewed for the next 5 years. The reentry project is one. We also have continuation of the foundational community support program, and there are a variety of other programs as part of that waiver.
CMS, the Centers for Medicaid and Medicaid Services, has issued a new set of rules. I can't quite believe this, or maybe I should believe this, that run something like 14,000 pages.
1,400.
Okay, 1,400
Yeah,
pages.
they weren't
That's a
that
little
bad.
better,
They
but
were a
that's still
lot, but not that bad. Yes.
Have you asked AI to interpret them for you or to explain
I
them?
haven't. Maybe
Try
I
it.
should.
See what happens.
Yeah.
But they're having this is rules having to do with eligibility, access, and home and community-based services. In a nutshell, what is CMS telling you?
CMS is telling us that we need to do a better job of transparency. We need to do a better job of assuring that people know how to get care. They have access to that care in a timely manner. We know that they have access to care in a timely manner. And that we simplify sort of the client, member, patient. I'm a provider, so I always go to patient experience in accessing both Medicaid in general and those services after that. So really trying to make it more patient-centered, more patient-focused, have us as well as the managed care plans we contract with be more transparent, so we show our work, and really try to just move forward in making it easier for people to enroll in and access care and find services.
Do you see these 1,400 pages in rules helpful and productive, or is this just more mandate from the federal government?
No, I think they're well considered. I mean, more work is always more work, and with more work comes requests for more funding and finding more staff to do it, because we already are fairly lean. So it is more work, but I don't think there's anything unreasonable in saying if someone has a need for a medical appointment, they should have it in 14 days. And if it's a mental health appointment, it should be in 7. We should all aspire to that.
So just lastly, in the little bit of time we have left, this does raise the constant issue of providers who will take Medicaid. And we know we've already got a pipeline issue, a workforce issue. What are you observing about your ability you can get people the insurance, but can you get them the services they need?
I think that the legislature has been very supportive in doing a couple things. They've provided a number of directed payments over the last number of years to behavioral health providers, recognizing the workforce shortage and the need to get staffing. There have also been some directed rate increases for primary care services, OB, family medicine, internal medicine, pediatrics. So the legislature has recognized the need to keep up. One of the other pieces that CMS has put out in these rules is that states have to start to build their Medicaid rates closer to matching Medicare. And I can't recall the percentage we're required to do that each year, but they're saying, step it up, states. Let's try to align better to improve access.
Okay. I'm going to stop you there. Dr. Charissa Fotinos, the Medicaid Director for the state of Washington. Thank you so much for coming in to talk about this.
Thanks for the opportunity.
Thank you for watching Inside Olympia, and we will see you again next week.
Support for Inside Olympia provided by